Thanks so much for having me. It's just such an honor to be here with just so many superstars in the field, and I feel very humbled and really excited to share some things with you about imaging and as a biomarker. I know there's been a lot of talk about biomarkers, and really just kind of wanted to do a few things with the time that I have. Kind of number one, go over where we are with imaging. We had a big discussion about this in our breakout session. What does it do now? What's the relevance of it right now today for TBI and in the way that we use it clinically? Number two, what can we do with imaging in terms of using it as a quantitative tool rather than as a qualitative tool like I use in my clinical practice? And then number three, what are new and emerging different ways of imaging the brain or collecting data from the brain that look at function and structure and maybe get at that endophenotype of what's going on. And then a little bit about how one might analyze these data. What do you do with all of these data and how do you approach it? And then another big theme from our breakout session was how do you start to validate these imaging biomarkers, or any biomarker for that matter? What do you compare it to? Do you compare your biomarker to symptoms? Do you compare it to something else that you're measuring? What are the options? And I have one possible approach that I can talk about. And so maybe do I switch slides with? Gotcha. And there's my disclosures, some NIH funding, and then NCAA DoD funding. So I won't spend a lot of time here because I think we know all of this information that traumatic brain injury affects a lot of people. There are a lot of causes for traumatic brain injuries, including falls, motor vehicle accidents, assaults, sports-related injuries, which is what my funding is based on, and that the symptoms can be pretty diverse. In terms of sports, which is what I study, looking at sub-concussive exposure, here are the big offenders. But I think in the military population, in our service members, it's a little bit different. Blasts, falls, motor vehicle accidents, fragments, shrapnel, bullet wounds, et cetera. So different mechanisms. And of course, the costs are high. I think we all know that. And that traumatic brain injury is thought to be a gateway to other kinds of neurodegenerative diseases, and therefore just important to understand what's going on in the brain with respect to these pretty devastating injuries. So, what is the role of imaging? We use it all the time, especially I'm at a level 1 trauma center, so we see an enormous amount of trauma. It's a huge part of my practice. So, how is imaging used in the acute situation? How is it used in the chronic situation? So, the American College of Radiology published this paper several years ago, talking about the evidence. What is the evidence that we have for using at least conventional imaging, CT, conventional MRI, for traumatic brain injuries? And so we used a pretty rigorous approach looking at different levels of evidence in a big review that we did, and then made recommendations that had, based upon this classification system, based upon different levels of evidence and different confidence in the data that we were seeing. And the bottom line is, at least for acute to moderate to severe TBI, I think most people are familiar with this approach, that basically non-contrast head CT is the first line in imaging in the acute phase and can predict mortality and unfavorable outcomes in these patients, and it was a class 1 recommendation. MRI might be indicated in the acute setting when non-contrast head CT findings are normal, or if there's persistent symptoms. And specifically, we do have some MRI sequences that are very sensitive for blood, but whether it's really going to change outcomes beyond what we can find with CT is unclear. And here's just some examples of that. I mean, it's very clear. You have if someone comes in with an acute trauma and we scan them with non-contrast head CT. Number one, it can show you a lot of the bony trauma that they have, but you can also see things like subarachnoid blood, epidural hemorrhage in the middle, subdural hemorrhages, et cetera. Surgical emergencies that need to be addressed right away. It can also show subtle blood products that you maybe don't see. MRI can show you some subtle blood products that maybe you don't see on non-contrast head CT. There's a little bit of blood in the interpeduncular fossa. You can see it on a T2 flare a little bit better than you can on non-contrast head CT. And then occasionally you'll have cases where maybe the normal head CT is, the head CT is unremarkable, but the patient's very symptomatic. This is a patient with a long bone fracture and had a lot of fatty emboli that we could find with MRI. So there's a place for MRI, but obviously CT is the primary bread and butter modality. And and in terms of acute versus chronic, this is a patient that I saw. It was a young person who was hit by a motor vehicle. You can see a lot of intracranial gas. You can see a little area of low attenuation in the inferior frontal lobes. In the acute phase, the child survived the injuries, started to have seizures, had EEG with some abnormal findings in inferior frontal lobe, and of course MRI can show that there's some encephalomalacia change there in the brain. So pretty good at acute and chronic changes in brain, particularly for more severe traumatic brain injury. But then there's the issue of when conventional neuroimaging fails, and this is more for the folks coming in with mild traumatic brain injury. They've had an event, they're symptomatic, they come to the ED or come to their clinical care provider. Imaging is conducted. I look at it and I qualitatively look at it and I say, well, I just don't see anything there. However, they're symptomatic, so something is going on in their brain. Why are we so limited? There are many papers out there. If you look at diffusion imaging or bold imaging, and you look at mild TBI, people who are symptomatic but otherwise have normal imaging, where we see all of these changes reported in the literature, why aren't we using those kinds of methods in routine clinical practice? There's a lot of reasons for that I'll talk about. But what are those kinds of quote unquote advanced neuroimaging methods that people are using to categorize or try to understand what's going on in these patients who have had some sort of mild traumatic brain injury and who are symptomatic? So lots of different tools to choose from, including advanced structural imaging. It can be DTI, it can be advanced diffusion, kurtosis imaging. It could be neurite orientation, density and dispersion, whatever kind of diffusion you like. It could be blood flow imaging to look at blood and how that's autoregulated in brain. It could be resting state bold to look at network connectivity. But all of these methods have been shown to at least be able to identify changes in brain compared to a control group. But of course, as a physician, I don't have a control group. I just have the patient in front of me. So how do I make sense of these data, and what can we extract from these kind of data that might be able to help us in clinical practice? And I think this leads us to the idea that these imaging data, they're more than just pictures. There's actually data in them, and there's this term, radiomics. It's just another term, an omic term. You've got metabolomics and proteomics, and so they were trying to think of what's the omic that relates to these imaging data, and it's radiomics. I'm not real crazy about the term, but there it is. So it's an omic. These are big data. There's highly granular information that is embedded in these data sets at the voxel-wise level with signal that we can extract and potentially use to ask questions and understand what's going on in the brain of people who have suffered these injuries. And this kind of gets at that there's becoming this paradigm shift in how we use these data. As a physician, as a neuroradiologist, I'm using a qualitative approach. So I'm using my eyes to look at an image, and I'm looking for something that looks abnormal. And I identify the abnormality. I come up with the differential diagnosis, make some kind of recommendation. But what happens when there's something that is abnormal in the brain that we can't see with our eyes? Is there signal there in the brain that there's something abnormal there, and can we use more quantitative approaches to pull that signal out and make sense of it? And that's maybe the next phase of how we practice with these kind of data. So I kind of did, I kind of did an experiment where, I'm going backwards here. where I asked that question. I said, can I protocol a study? Can I protocol an MRI and acquire a quantitative data set that I can both look at qualitatively? I can look at it and use my search pattern and look for abnormalities just like I normally do, but that the data quality is sufficient that I can use these same data to then extract quantitative metrics from. So I protocoled it. This was a test patient that was coming in. We got T1 weighted images for structure, T2 flare. I got a diffusion image instead of a 6-direction diffusion just to look for restricted diffusion like stroke. I got a multi-direction diffusion so I could look at white matter tracks, arterial spin labeling for blood flow, resting state bold to look at network connectivity, just to kind of see what we could do. So here are those data. So there's the T1 weighted image. It's a high resolution isotropic T1 weighted image from which I can extract quantitative measures of volume. But so I might look at that and say, okay, well, maybe there's a mild degree of diffuse cerebral volume loss. So that's one thing I can do with those data. That would be the qualitative approach. Or what I did was take that data set and segment it into all of these different areas of the brain so I can look at the volume of white matter, volume of gray matter structures, and look at individual volumetric measurements of different regions in brain, like hippocampus. That would be the quantitative approach. I can look at this T2 flare image, and I might say in my clinical practice, whether there's some hyperintense T2 flare signal abnormality in the periventricular and subcortical white matter compatible with a moderate degree of chronic microvascular ischemic disease. Well, that sounds great, but what do we do with that? That's one way to do it, qualitative approach, just describing what's there. The other approach is to actually segment out that white matter lesion volume. So now we have a volumetric measurement, and we can look at the volume of that white matter signal abnormality. We can look at the distribution of it, and maybe that's going to be more helpful. Not sure. We can take this diffusion image. Normally, I would look for a bright blob that would suggest some restricted diffusion, either a stroke or blood products can be hyperintense on diffusion. Pus, infection, there's lots of things that can be bright on diffusion, but it's more of like, is there a diffusion signal abnormality or not? It's like this binary decision. Or I can, take that same data set and this is a movie that hopefully will play in a second, but I can take that same data set and then basically model all the white matter tracts in the brain, and then I can make actually quantitative measurements from all those different tracts. This is that same patient. And look at white matter tracts that might be important for the disease that maybe they're coming in with. This was an older gentleman who was concerned about dementia, Alzheimer's disease, so I just kind of pulled out tracts that might be related to dementia. But it could be any other disease, it could be any white matter tract if they have a certain symptom, for example. And then blood flow imaging. So we can acquire arterial blood flow data, and we can even map the vascular territory by individually spin tag labeling individual vessels in the neck and showing where the blood's coming from, and get a quantitative measurement of blood flow in all the different regions of interest, which might have some relevance. And then we can take I think I acquired maybe something like 8 minutes of resting state bold and constructed some networks for this patient. This is his global network connectivity. He was really interested in his hippocampus, so I looked at connectivity between hippocampi. That's what that dense red line is between the hemispheres of the brain, and then how the hippocampus connects with a bunch of other regions in his brain. And then, then that's another quantitative metric that we can derive out of these imaging data. And then, what does that look like? How does one coalesce all of those quantitative measurements? Well, then, you could have sort of a quantitative readout of those data. So you can see on this slide, I have whole brain volume, hippocampal volume. I have different measurements from the fiber structures that I measured. And then I took just sort of a population of patients off of our, that we had on the research side, where I had these quantitative measurements, and just sort of 30 or so, just as a, sort of a theoretical exercise, just to see if I could get a normal range and then determine where this patient fell within that range, which can be done. So I have my age-matched, normative data set, And there you have it. Those are kind of where he falls within this normal population. And then even for network measures like global efficiency of brain, small worldness, interhemispheric connectivity. So it can be done. I think the limitations of that approach is that if he came in again and I scanned him on the same scanner using the same protocol with the same software platform, I'd have a good chance of getting good longitudinal data. If I went to another scanner, that's where we run into problems. So, there might be 30% error between scanners, and so, that does not facilitate a longitudinal approach using a quantitative metric in a patient. Luckily, Lisa Wild and Walt and others have this great VA sponsored Phantom that Mike can address that we've talked about in some other sessions that Mike could maybe decrease that error, and just like we have standardized CT, we can maybe standardize MRI and maybe get better measurements. So I think that's a need. And then the next thing is, are there other imaging options that also provide similar kinds of quantitative precision medicine data? And there are, that maybe get at some of the endophenotypes. So I think we all know that autonomic regulation of blood flow is affected by TBI. So can we measure autonomic regulation of blood flow? Yes, we can, by just giving a CO2 challenge, which is the thing that drives blood flow and brain, and producing a little bit of hypercapnia. Here are some data showing changes in cerebral blood flow and then changes in BOLD by inducing a little bit of hypercapnia, and you can see that it follows a dose response, low, medium, and high for the different degrees of hypercapnia. There's the device. You can put it on, slide someone in a scanner. This was one of my colleagues, brilliant guy. He volunteered to get in, and you can see that on the top row, the blood flow image. If you look down at the bottom, his end-tidal CO2 was about 42.55. End-tidal O2, 112.1. If you look at the next one, that's where we induced a little bit of hypercapnia. So now we've bumped up his CO2 to about 51.6. O2 is as good or even better. And then you can see, just visually, you can see the difference that the second row is a little bit brighter, more blood flow, and then the bottom row is just the subtraction between the two, showing where you get more cerebrovascular reactivity from hypercapnia, often in deep gray structures, which are super hypermetabolically active. So a great measurement. What's another tool that we could use? Most MRI is based upon, when someone says functional MRI, they're really talking about blood flow. Everything in functional MRI, or most imaging modalities, are linked with some change in blood flow. And that can either be a change in the ratio of oxyhemoglobin to deoxyhemoglobin, like BOLD, or it can be absolute blood flow, like in ASL. But all of those methods are predicated on the fact that you have good autonomic regulation of blood flow in order to get an accurate measurement. Here's another way of measuring function, but instead of looking at blood flow, function in the brain is really electrochemical. Well, every electrical current has a perpendicular magnetic field, if you remember your right-hand rule from physics, and we can measure that magnetic field with MEG. And let's see, on the next slide, just kind of shows how electrical activity is the blue line, the red circle is the magnetic field that it produces. I won't go into the physics of squid detectors. And here's a map of where all the MEGs are in the world. There are more now. And so you can see there are a fair number of them, so you could do multi-center trials if it was truly a sensitive and specific measure that gave you novel information about the brain, then there they are. And if it was really valuable, then you could make more of them. I mean, MRI, people thought, well, who in the world is going to use this giant, magnet to look at the brain? It's so impractical. But it has utility. So now you see MRIs everywhere. If MEG was shown to have value in neurodegenerative disease, TBI, et cetera, then maybe you would see more of them. But you have to figure out how to use them first. So there they are, and that's our MRI, our research MRI. There's our MEG. It's one of our research patients, and the red dots are just a cloud of data that you acquire from MEG, and then you beamform that into brain and can determine where the signal comes from. And you can do things like pull out default mode activity. We published this in Neuroimaging several years ago, just showing that you could model default mode network activity using MEG, just like you can with MRI, except you're not limited, it's not driven by necessarily blood flow signal per se. It's driven by electrical signal. We're using MEG a lot in the TBI domain looking at delta waves. They're these really low frequency waveforms that tend to go down as you get older, but become high again if you have neurodegenerative disease or TBI. The interesting thing is that it seems to be a very sensitive marker of exposure. So these are data from our football players. We're studying sub-concussive exposure. So these are kids who are hitting their head a lot of times, maybe 1,000 times in about a 3-month period. And frontal impacts are what it says. They're hitting their head in the front. Top of the head are, where their head is hitting at the top. And so when you look at these data, our engineering colleagues, when they first saw these, they said, well, that doesn't really make a whole lot of sense because the abnormal signal's on the opposite side from where they're hitting. And from the clinical perspective, we said, no, that makes perfect sense. That's like a counter-coup injury. So none of these players had a concussion. They just were exposed to a lot of head impacts. And certainly, MEG seems to be sensitive enough to pick up some of those changes, and therefore, might provide a really sensitive biomarker for maybe subconcussive exposure. So maybe in the military, that might be firing, shoulder-held weapons, or hitting the ground hard after parachute jumps, which there's a lot of force associated with that. You might not walk away with a concussion, but are there things that we can measure that are related to their exposure, and what can we learn from that? So just another tool. So then there's molecular imaging. So this is a processing pipeline in my lab for taking PET CT data, taking MRI data, combining all that together to then extract quantitative metrics from individual regions in brain. And we do a lot of development work at Wake Forest, developing new ligands. We have a cyclotron. We have an extraordinarily talented radiochemist that I work with, Karan Sai. This is a lot of his work. So, we can do things like, oops, sorry, I went too far. So this is, amyloid, but we do amyloid, tau. We have a very active Alzheimer's disease research center, direct their imaging core. These are kind of the data that you can get and where you can extract quantitative metrics from brain using these very specific ligands that try to get at mechanisms. This is acetoacetate. We have a big primate center at our facility, so we do a lot of development in primates to develop ligands first in primates and then use them in humans. Acetoacetate measures ketone utilization in brain, and we were one of the first in the country to combine acetoacetate and FDG to look at ketone utilization and glucose utilization simultaneously by labeling, using F18 for the for the deoxyglucose and using C11 for the acetoacetate, so we can do it simultaneously. And then you're asking questions about the fundamental energy metabolism in brain. It's known that for diseases like Alzheimer's disease, if you look in the hippocampus, there are some patients that switch over from using glucose to using ketones. We wonder if the same thing occurs in the brain, of folks with trauma. But we can ask those questions, and we can do it in a very efficient manner using simultaneous imaging. Won't get into this a lot. It's a glycogen synthase kinase 3 that we've developed and are using. It's just one that's involved in cell differentiation, development, metabolism, cell cycle regulation, has been associated with neuroprotection. But I guess people are using it in the Alzheimer's disease domain, mood disorders, type 2 diabetes, and in some neuro-oncology studies. But we have that. Then we've developed this really nice, that I'm kind of excited about, microtubule agent that binds to microtubules in brain. If you recall, microtubules are the things that help push vesicles of neurotransmitter from the soma out into the synapse. So, it's somewhat nonspecific, but, like, let's say the diffuse axonal injury, which I agree, I think that's kind of not exactly sure about that term. I certainly can't see axons, on an imaging study. So it's a label that refers to a pathophysiology. Well, perhaps this is a way that we can look at those axons and look at functions of those axons and mechanisms in axons that might be transmitting neurotransmitter to synapse, which then might lead to different kinds of symptoms depending on where the injury was. This is showing binding in a rodent. You can see that we can block it, and it's has very high levels in brain. So that's a rodent. That's not super exciting. Just recently, we've put it into one of our primates, and you can see that there's really high specific activity in brain. So we're really excited about this and starting to use it in the Alzheimer's disease domain and neuro-oncology. But I hope is to bring this into TBI. Then, how could you use molecular imaging for trials? So this is a device that has been developed at Wake Forest. You might have heard of the wound vac. So it's a device that for big injuries that soldiers incur on the battlefield. And typically the historic way of treating those injuries is to let them close by secondary intention, meaning that you don't sew them together, you just leave them open, debride them, and then let them grow together. Well, if you use the wound vac, which packs it with this material and puts a film over it and then adds vacuum, those patients do a whole lot better. So now we're trying to think of how to extend that same technology to soldiers on the battlefield who may have had traumatic brain injuries. So if you have a big injury in your brain, then one way to treat that, and you have a lot of mass effect and you're herniating, is to do a craniectomy. So the question is, would you do better if you had something covering that craniectomy site with a little bit of vacuum? We've published that it does improve outcomes in a pig model, but we started wondering, how does that work? What's the mechanism? And we wondered about neuroinflammation. So I thought, well, let's take our pig model. Let's do this procedure with the device applied, but not activated, with the device activated. And let's measure something like neuroinflammation with PBR28. So that's what we did. On these images, you can see the one where the device is not activated, the big red dot at the top of the brain. That's kind of where the injury was. With the device applied, you see less red. Interesting. It's an N of 1 pig, and here are those quantitative data. You can see the blue is at baseline. Baseline's about the same. You have much higher measurements of neuroinflammation with PBR28 when the device isn't activated compared to when it is activated. Again, this is very, very preliminary and not meaning to say that this is definitely going to work, but just as an example of what you can do with molecular imaging for trials that you're pursuing to improve the health of soldiers and other TBI survivors. And then I just inserted these as I heard the discussion up here where people were saying, well, if we only had methods that we could both use in humans and in animal models, well, I can tell you that imaging, at least, everything that you can do in a human, you can do in an animal. So these are some of the primate data that I've been able to pull together really quickly, just showing that we can take the brain, segment it into all these different regions, just like we can with a human. We can do advanced diffusion imaging. So here's diffusion kurtosis imaging, cerebral blood flow imaging. Here's a human compared to a non-human primate. Their default mode network. You can see that you can recapitulate that in animal models. And all of this you can do in pigs. So I'm starting to do a lot of this in pigs, which is a common model for TBI. So all the kind of imaging that you can do in humans, you can do in pig models of TBI, which open the door to sort of using these imaging biomarkers and really validating them in animal models. And then I only have about a minute left, but I'll just talk about, how do you, so we have all these great quantitative imaging biomarkers. How do we use that data? And what's the problem in TBI? Well, one of the problems is that you have these two groups, TBI, non-TBI, with a general linear model. You're trying to compare them. But the problem is that sometimes, if you have two groups that are really separated, no TBI and TBI, your sensitivity and specificity with a general linear model approach is going to be great. But what happens when you have diabetic patients who get TBI? What happens when they also have hypertension? Hypertension affects the brain, so does substance abuse, so does obesity, so does coronary artery disease, so does ischemic stroke. So all of a sudden you have these two groups, like a real world population in TBI, that may have similar conditions affecting the brain. It's just that one also has TBI. So it becomes where it's really nearly impossible to separate these two groups. Poorly defined. So what can you do about it? Well, there are other ways to do it. You can take the TBI group and the comparison group, and you can plot them on one axis. and then you can plot them on another axis. You can transform the data in high dimensional space, and you can find a way to separate them using just the support vector machine approach. And so this is like this is very, very simple. There's convolutional neural networks, deep learning, other methods of doing this. This is just a very simple data mining, so-called data mining approach that you can use, and that's one way you can use these data. We've done it with sub-concussive exposure, and we can take ones that have a lot of head impacts and some that have fewer head impacts, and we can categorize them in that way. And it can tell us how it did it, and it was because of these differences in these midline structures. This was for functional connectivity. And the great thing about these methods, and there are many, I'll show you support vector machines, kernel functional mapping, support, ensemble classifiers, artificial neural networks, deep learning. We've done it with Alzheimer's disease. This is some work that we published several years ago just showing that you can take T1 data and classify someone as having Alzheimer's disease, mild cognitive impairment, or normal. The great thing about these methods is they do better with more data. So, again, you can't use these imaging data in a vacuum. It's much better when you use this as one feature and combine it, just as we do in medicine, with history, physical exam data, laboratory data, putting all of those data together. So I can't remember the person who said, there's all these biomarkers, and what do you do with them? I have a list of 50 biomarkers, and they say, good luck. Well, what you can do with them is you can start to use them as big data, using them in these classification algorithms, and then you can start to have really complex data sets and identify different phenotypes and endophenotypes of patients and stratify them for clinical trials. And I think that approach, I think, might have some important effects on the field. And then finally, I'll just make the pitch for, I'll go through this really quickly. The pitch for the idea that what should we validate our tools against? One idea is, why not validate it against biomechanical exposure? I mean, it's the impact itself that we're really interested in. If you were doing a drug trial, what you'd want to know is the dose of exposure and then how much that changed your metric. It's been difficult to measure exposure, but we have devices now that can do that. And when you do use those, you have the ability to treat exposure like a drug trial. So you can do time course curves. You can look at dose response. That's what we're doing with our studies of subconcussive exposure. And there are devices that couple tightly to jaw that look like they are going to perform well. Again, there's no perfect method of measuring mechanical exposure right now, but you have to start somewhere. And if we iterate enough, maybe we'll get something that's very accurate. But you can take those biomechanical data, and then you can start to regress it out, taking data from different parts of the brain and showing that as your exposure increases, your brain changes. And perhaps that's one way to validate our methods. Not sure if that's the right way or not. About the only way you could do that, you certainly couldn't do that in like a normal population. Sorry, I'll go through these really quickly. But you could do it. You can model it in things like sports. You could model it in our military personnel. So you image them before they go out to battle. You image them when they get back. You acquire all the biomechanical data in between, and you look for changes. These are kids that hit their head about 1,000 times over a 3-month period. And then you can take those data and you can start modeling them, building models of the brain. So this is one we're developing at Wake Forest. We're taking imaging data, we're taking biomechanics like that hit, and then we're modeling it. And then you can start to say, where specifically in the brain is this person experiencing the most stress and strain? And we're starting to include in that white matter tracts. So you can see, there's a lot of motion in the brain for an individual impact. The key here is that you could take an individual participant, if you had these data, military personnel or a sports person, someone that you can instrument, and you can identify the specific region in their brain that has the highest shear and stress. That becomes their area where where the effects of their exposure might be centered. And then you can start to use those data to, group people differently based upon their exposure, based upon the location of exposure, based upon the magnitude of exposure. And then maybe you could sort of get somewhere with some clinical trials. But when you don't know where, when you don't know where in the brain each individual participant experienced the most stress and strain, you don't know exactly when the exposure occurred, and you don't know how much they had, just makes it very difficult to do trials in that situation. So we need some way of measuring that, and hopefully we'll develop better methods to do this. With that, I'll thank my funding agencies and take questions. Sorry, I ran over just a little. Yes?
Chris, I have a question. So there's been a lot of talk about big data and phenotyping, and clearly with EMR data that is sort of more classic data, we've done a good job of being able to collate that. But with imaging data, we're able to combine data from researchers, right, who are willing to sort of submit their data. But we have not done a good job of being able to harness the tremendous data that exists there that's clinical data. And so I'm wondering, do you have any ideas about the barriers that would exist to being able to do that, to be able to sort of, especially from academic medical centers that are collecting some of this advanced data but not necessarily using it?
Right.
Because, I mean, that data already exists, and if there was a way to collect kind of a limited amount of demographic and clinical data as well, it could be really useful potentially.
Yeah, I had some slides on that, and that I wasn't able to go over, but the American College of Radiology is working on that, and they have the Data Science Institute. So what their aim is to be the honest broker and to go in and go into these academic medical centers and say, let us help you mobilize your imaging data that's all stored in your PACS, and mobilize that to ask scientific questions and to utilize those data for AI algorithms, deep learning algorithms, and combine that with all the other electronic medical record data to actually come up with methods of classifying that might actually be useful in healthcare. So there are a lot of people working on this. The American College of Radiology in particular is really trying to push this. And so I think you'll see more and more that there is a mechanism to mobilize those data, and you're going to see those data trickling into the development space. So
is there a common repository yet?
Not a common repository yet, because we're thinking that common repository might be not the way to go, that we might want to keep the data at all the different institutions, but just be able to access it via some cloud interface. So I think the repository might not be in one location. It might be more cloud-based, and it might be a network of some sort of interface that allows you to access data from multiple different institutions. But that's being developed right now.
So I think one of the holy grail in concussion, especially for imaging, is to get a diagnosis for a diffuse axonal injury, which everybody's thinking but is sometimes afraid to say. Some people are bold about it. And so I was really interested in your microtubule ligand and how that might work. Can you join that with fiber tractography and whatnot?
That's exactly right. I mean, I think that would be the interesting thing, the interesting question to ask. Do we have can we identify somewhere in the brain where there's an injury, and we could use the microtubule maybe agent to do that, and hypothesize that in an area where you see some abnormality there, that you might see some diffusion change. And then you could look in areas where you don't have a lot of microtubule change, and use that as a within subject comparison. And then if you had a patient who, and then you could even go further and model the biomechanics. If you knew where a person had the most shear and stress in their brain, you could map their microtubule activation and also their diffusion. You could put all those three together to basically generate that kind of hypothesis and try to measure those kind of data.
And do you think that would get at, if we see a change in FA, nobody can tell me where that's coming from? Everybody's thinking axons, but it could be a lot of places.
Yeah, because there's many fluid compartments, many fluid compartments in that complex tissue. So whether it could or couldn't, I'm not sure, but it would be an interesting approach.